Thank you very much. Thank you for the invitation and for the symposium. So I have to be very careful because I see that if there are mistakes in the slides, there will be noticed. So yeah. Yeah, great. So so I've been working in a number of companies for collaboration and research. So let's go back to this issue of what is the effect of the support we give on the diaphragm. So this is a schematic representation of the load and what the ventilator can do and what the muscles can do. So here would be controlled mechanical ventilation. So all the load is taken by the ventilator. So the respiratory muscles are completely at rest. And we heard that this may not be very good. And during partial ventilatory support, we hope that both the ventilator and the respiratory muscle are taking some part of the load. But it is quite easy to have an inadequate setting, and in fact to have either, let's say this is two opposite examples of inappropriate assistance, either an excessive load with the respiratory muscle of the patients, or even an excessive unloading because the level of assistance by the ventilator is too high. So we are talking a lot of ventilator-induced diaphragm dysfunction and atrophy. This is not a new topic, and I think like Vili, this is something which takes years before coming into practice. This was probably the first human data suggesting in infants that there could be a diaphragm atrophy induced by mechanical ventilation. This was a case presentation, so not completely convincing. There has been a lot of animal data, and you know that now we have clinical data showing in maybe special situation that the diaphragm can atrophy, and you probably have seen this slide before. Where after 24 hours of mechanical ventilation or a bit more, you see clearly on the biopsy for the same scale that the fibers have a smaller diameter. So there is what we call a disuse atrophy of the respiratory muscles. And the animal literature is full of data showing that mechanical ventilation is a very good model. And there are some mechanisms at play which have been studied. For instance, in this study by Catherine Sassoon in rabbits submitted to 48 hours of mechanical ventilation. And you see a big difference between control and the control animals and control mechanical ventilation. What was very interesting and attractive for us clinicians was to say, well, if you use some kind of assisted ventilation, which means the animals are triggering, are breathing a little bit, there is much less signal, so there is much less disuse atrophy. So maybe most of us say, well, this is good, so maybe we don't have to worry so much about what's happening in our ICU because we often use assisted ventilation. However, other experiments show that, well, okay, but it's not because you use an assisted mode that you prevent this atrophy. And this paper was saying that high level of pressure support, here it's 18 centimeters of water of pressure support, it's similar to controlled mechanical ventilation in inducing atrophy. Oh, so we go back and say, maybe it's not because we use pressure support in many of our patients that we prevent this atrophy. So we need clinical data. And one way to look at atrophy in the clinical setting is to directly look at the morphology of the muscle. And the diaphragm ultrasound is a very interesting technique because with some precaution, you can detect the diaphragm between the two layers of the pleural and the peritoneum layer. And what is in between these two layers is the muscle, the diaphragm contracting. So you can, in M mode, measure the thickness of the diaphragm, and you can even measure the thickening of the diaphragm at each inspiration. As you know, when a muscle contracts, it thickens and it shortens. And this tool has been now used in a number of studies to detect the change in thickness. This was a study done in Toronto by Johan Erliger on more than 100 patients just ventilated for 24 hours or more, and looking prospectively daily at the diaphragm thickness and also at the diaphragm thickening, which means how much the patients are using their muscle. And what you see looks complex, but in fact is, I do the same trick. So it is, in fact, easy to understand. What you have here is the change in diaphragm thickness. And you see that for many patients, over the duration of ventilation, there is a decrease in thickness. And we think that when it's higher than 10%, it's significant because this is the limit of reproducibility of the technique. And approximately 40%, 40% of the patients develop decrease in thickness. So let's say develop atrophy. That's huge. That's not 1-2%, that's 40%. And this was clearly related to the duration of mechanical ventilation. And of course, if you look in this way, it's also related to the contractile activity, which means for the patients who are doing very little work, for instance, let's say high level of pressure support, there was a much faster decrease in the thickening. So we don't only have one factor, which is time, on which we cannot play a lot. We also have a factor on which maybe we can play, which is how much diaphragm activity the patient is performing each day. Well, you may say, but the figure is more complex because we even see some patients with an increase in thickness. Well, that was fascinating. We thought maybe that's good. The muscle is getting better. But we think that's probably not getting better, more fibers. That's probably getting more edema or injury. And in fact, the patients who had an increase in thickness were the patients who were working harder. Well, and that was approximately 15% of the patient. So if you don't give enough assist, there will be injury to the muscle. And if you give too much assist, there will be atrophy. Well, that's a very difficult job for the clinician. You could say, okay, you show diaphragm atrophy, you show diaphragm increase in thickness. Does it matter? And that's a difficult and important question, because if we want to change our practice, we have to show that it has an influence. This was a study looking at the level of phrenic nerve stimulation, the twitch, the pressure generated by phrenic nerve stimulation in controlled subject, in patient with absolutely no diaphragmatic dysfunction tested by voluntary maneuver, so which means their maximum pressure was high, and in patient with diaphragm dysfunction. And you see that there's a very clear separation with the phrenic nerve stimulation technique. And when the twitch is at 11 centimeters of water or below, it's a clear sign of diaphragm dysfunction. So that's an interesting test because you don't need the contribution of the patient, you don't need the cooperation of the patient, and you can do that in ventilated patients. And this technique was used by Martin Dress in Paris to address the question, he addressed, let's say, 3 questions. The first question was, is diaphragm dysfunction frequent at the time when we start weaning from mechanical ventilations? This is medical patients, so in a medical ICU, and he said, let's look at how many patients have a twitch pressure which is 11 or below, so that this is clear dysfunction. How many patients have a normal twitch pressure? And the first answer here is that 60% of the patients have diaphragm dysfunction. That's very interesting, because if you remember the 40% who had the decrease in thickness plus the 15% who have an increase in thickness, that's approximately the same percentage, 60%. The second question he asked was, is it the same disease or syndrome than limb muscle weakness, the classical ICU-acquired neuropathy? And that's why he plotted the twitch pressure versus the MRC score. And he found that, well, there is some overlaps here. So some patients who have a low MRC score and a low twitch pressure, but you have much more patients who have normal MRC score but still have diaphragm dysfunction. So the answer is clear. No, it is not the same disease. There is some overlap, but it's an independent mechanism. And it's probably, we don't know here, it's frequently related to mechanical ventilation. So the third question he addressed is, does this impact the weaning success or failure? And the answer is yes. There is a very large impact. This is two ways to present it. So this is the 3 categories of weaning, let's say simple, difficult, and prolonged weaning. And you see that this is the prevalence of diaphragm dysfunction in simple weaning, in difficult weaning, and prolonged weaning. Well, interesting to note, you may have diaphragm dysfunction but still be able to wean, right? You're still breathing. If you have no other problem, it will be okay. So there is only 60% of patients in simple weaning who have no diaphragm dysfunction, the other do. But if you have difficult or prolonged weaning, it's almost 100%. So there is a very, very strong association suggesting a very strong impact on diaphragm dysfunction at the time of weaning and further weaning difficulties. And that's the same for duration of weaning, duration of mechanical ventilation, etc. More than that, this is a study we did in Geneva, following patients who were admitted with hypercapnic respiratory failure and following the patient after discharge. And you know that in the hypercapnic patient, one of the big problems is readmission. And we found that using a different technique, which is the sniff evaluation of the diaphragm, those patients having muscle dysfunction had a much more frequent rate of hospital readmission and ICU readmission. So it's not only a problem for the ICU stay, but it's also a problem for what will happen after ICU discharge. And there is an additional problem that it's not only the quantity of work, but it's also the synchrony between patient and ventilator. There are a number of studies showing association between interaction and duration of mechanical ventilation, poor ventilator interaction and duration of ventilation. There is one study by Louis Blanc who showed an association with mortality. And the most recent study comes from Dimitris Georgopoulos and his group, and they looked at patients who developed what they called clusters of asynchrony. And a cluster of asynchrony was here, this is a time scale, and was defined as having at least, let's say, 50% of the breaths which are asynchronous over 3-minute periods. And he found that was the most informative predictor of bad outcome. You see patients who develop clusters of asynchrony, have clearly a longer ICU stay, longer duration of mechanical ventilation in total or after the event. So more and more data associating desynchrony, asynchrony, and a poor outcome. So how can we monitor? So I agree with Giacomo. The reference technique to monitor the respiratory muscle is esophageal pressure. And I just put here the tracings you obtain in controlled mechanical ventilation, up, so the pressure goes up during each breath, and during spontaneous ventilation. In fact, when you want to measure the muscular pressure, ideally you should calculate the difference between the two. So this is a very beautiful technique. This is a reference technique, but I agree this is complicated. And monitoring the diaphragm EMG may be an easy technique to do that. This is a nice example because you have pressure support ventilation, which looks very regular and very nice with a respiratory rate of 18. So if you already have a good eye, you see that these small changes in airway pressure and flow may be something else. And in fact, when you have the diaphragm EMG, you realize that there were 2 missing breaths here. So in fact, the real patient respiratory rate is probably more than 30 to 35. And this is an example, if it's over, let's say, 3 minutes, that would be a cluster of asynchrony. So very concerning. This is another example where, again, you can recognize maybe these ineffective efforts, which indeed correspond to diaphragm activity. It may be much more difficult to recognize this one or this one, which is picked up very nicely by diaphragm activity. So to really monitor the real activity of the diaphragm, that may be an interesting tool. We showed in a recent study that it's possible to improve even pressure support ventilation by using the electrical activity of the diaphragm. And we showed, for instance, that we could reduce the trigger delay or the time in excess after the end of the breath. A last interesting tool with EDI, and I'll finish in my time of, I'm in the red, I see now, is that you can even monitor the respiratory muscle activity when there is no respiratory muscle activity. What do you mean? Well, I mean, if you place the catheter correctly, and placement of the catheter is mostly based on the ECG tracing you see, you can detect exactly when the patient starts to use his or her respiratory muscle and when the patient starts to really breathe spontaneously. Because we saw in all the study that the initial period of 24, 48 hours is critical. And in fact, probably this is the period where we say, well, it doesn't matter too much. And when Leo Hunks was with us in Toronto, we decided to launch a study to look at every intubated patient, to put a NAVA catheter at that time, not to do NAVA, but just to monitor the EMG, and to know when the patient would start be activating a respiratory muscle. So this is an example, the patient at day first, this is a placement of the esophageal catheter. You see no diaphragm activity, and you see that the patient has no EDI. So this is the trend over the first 24 hours. You see no activity or very, very low activity, below 5 microvolt, for instance. It never reaches 5 microvolt, which would be the minimal level of respiratory muscle activity. On day 2, still no activity. The patient is still sedated and has opioids. So classical patient admitted for acute respiratory failure. On day 3, propofol has been stopped. The patient is still on some opioid infusion. You see some weird tracing, which probably have been recognized by some of you as being reverse triggering. So this is why the EDI peak is increasing. On day 4, it's still some reverse triggering. And it's only on day 5 that these patients started to have a, let's say, normal respiratory muscle activity. So we say, well, we do not worry too much about the first initial hours on mechanical ventilation. Well, it can take 5-6 days very easily, and that will be a patient very likely who will have diaphragm atrophy and weaning difficulties. So we are continuing these studies. This was the result of the first initial 15 patients. We are close to have 80 patients. And thanks to the whole team in our group in Toronto, our research fellow and respiratory therapist, we are close to achieve our goal. So in conclusion, I would reinforce the message given by speakers before me. I think monitoring diaphragm activity, diaphragm function, and patient-ventilator synchrony is going to be key in the future, and we need tools like esophageal pressure or electrical activity to do that. Thank you very much.